Imagine for a second that you are looking at a chest x-ray. You're staring at this glowing black and white image, and right there, where you should just see healthy black, air-filled lung tissue, you see this hazy, ominous white patch.
Yeah, it's a very classic image. To the untrained eye, and honestly, frequently even to experienced clinicians, it just looks like one big monolithic failure of the lung.
Right. But beneath that single white shadow, there's actually a tale of two entirely opposite physical processes. So today's mission for this deep dive is to decode two classic, heavily used respiratory terms. We're looking at pneumonia and atelectasis.
Two terms that get mixed up all the time, by the way.
Exactly. So we are stripping away the medical jargon to break apart the history and the little mechanics of these words. Because revealing how to read respiratory diagnoses is, it's less about memorizing vocabulary and much more about understanding the fundamental physics of the human body.
It really is. The vocabulary actually becomes completely intuitive once the underlying mechanics are clear to you. We spend so much time looking at that two-dimensional shadow on an X-ray that we sort of forget the lung is a dynamic, three-dimensional structure. It's subject to the laws of fluid dynamics and gas pressure.
To frame this whole analysis for you listening, think of the alveoli, your lungs' tiny air sacs, not as simple empty spaces, but as this vast pressure-dependent pneumatic scaffolding. It's a highly delicate, semi-permeable network.
That's a great way to picture it.
Yeah, so when that system fails and shows up as a white patch on imaging, it basically comes down to a structural diagnosis. Did that scaffolding get flooded from the inside out? Or did the structural walls just cave in entirely?
Right, because in radiology, regardless of which failure occurred, that white patch is simply called consolidation. It's a great umbrella term. It merely indicates that a space that was previously filled with air has just been replaced by something denser.
Okay, so the distinction lies entirely in what that replacement actually is.
Exactly. So pneumonia represents the flooding mechanism. It is a profound inflammatory process. A pathogen, so a bacteria, a virus, or a fungus, breaches the gas-exchanging tissue.
And then the body fights back.
Yeah. The body's immune system detects the invader and triggers an acute inflammatory cascade.
I want to break down that cascade for a second because we often just say inflammation and kind of leave it at that. What is physically happening to turn that black air space white?
So the local capillaries dilate and they become highly permeable. Basically, they get leaky. This allows plasma to leak directly out of the bloodstream and into the alveolar spaces.
So it's filling up with fluid.
Right. And following that fluid is an army of neutrophils. Those are white blood cells that literally squeeze through the capillary walls to attack the pathogen. As they break down the invading bacteria and die off, they form this thick, protein-rich exudate.
Basically pus.
Basically, yeah. But the key here is that the architectural structure of the lung is still perfectly intact. The walls haven't collapsed at all, but the airspace is utterly flooded with fluid, pus, and cellular debris.
Which brings us to the opposite structural failure, right? Atelectasis, the walls caving in.
Exactly. Atelectasis is a purely mechanical failure. It requires absolutely no pathogen, no immune response, and no inflammatory fluid. It is simply the loss of lung volume.
The pneumatic scaffolding deflates.
Yes. The alveoli just collapse inward on themselves.
But the physiological consequence for the patient breathing in that hospital bed is remarkably similar, isn't it? In both scenarios, the patient is starving for oxygen.
They are, and that's due to a concept known as a VQ mismatch.
Walk us through that.
Sure. So ventilation, the V, is the air actually reaching the alveoli. Perfusion, the Q, is the blood pumping past them. In a perfectly healthy lung, they match up perfectly.
Makes sense. Air meets blood, oxygen transfers.
Right. But in both pneumonia and atelectasis, the right ventricle of the heart is still diligently pumping deoxygenated blood right past these damaged areas.
But because the alveoli are either flooded with debris or physically squished shut, the air can't get there.
Exactly. No gas exchange can occur. The blood essentially bypasses the lung's filtration system without picking up any oxygen. We call this shunting, and it results in severe hypoxemia.
Okay, I have to challenge the reliability of how we actually detect this, though, specifically regarding the X-ray, because we treat the radiograph as this infallible truth-teller.
Oh, it is definitely not infallible.
Right, because if pneumonia is defined by this visible inflammatory fluid fill-up, what happens when a patient is severely dehydrated?
Or immunosuppressed.
Yes, like what if a patient has leukemia or is undergoing chemotherapy and they are neutropenic? Meaning they physically lack the white blood cells needed to mount that immune response in the first place. Could you have a lethal infection that remains completely invisible on an X-ray?
You absolutely can, and that exposes a major flaw in how we traditionally define the disease. A patient with profound neutropenia might have a raging bacterial proliferation in their lung tissue, but because they cannot mount the inflammatory response, they can't send the neutrophils, they can't create the exudate. There's literally no fluid to cast a shadow on the X-ray.
Wow. So the radiograph looks entirely normal.
Completely clear. This is why the definition of pneumonia is constantly debated. Historically, it was a purely clinical diagnosis based on the sound of a patient's breathing. Then it shifted to a radiographic diagnosis when X-rays were invented.
But today, we realize that relying solely on imaging is a trap.
It's a huge trap. It forces clinicians to integrate microbiology, clinical presentation, and imaging into a much more complex diagnostic web.
It really highlights how our understanding is entirely dependent on the tools of the era, which means to really grasp why we use these specific diagnostic terms today, we have to look at how doctors were identifying these massive white patches before they can see them on a screen.
The diagnostic history is essentially a history of sensory enhancement. Take atelectasis. The term was coined way back in 1819. It derives from the Greek ateles, meaning incomplete, and ectasis, meaning expansion.
Incomplete expansion.
Exactly.
And the credit for that term goes to René Laennec, the French physician who famously invented the stethoscope. It's actually fascinating how social norms inadvertently drove medical innovation here.
The story of the stethoscope is wild.
Yeah, so in 1816, he needed to examine a young female patient's chest, but felt it was socially inappropriate to press his ear directly against her, which at the time was the standard method of auscultation.
Right, where you just put your ear on their back or chest. So he rolled a quire of paper into a tight cylinder, placed one end on her chest and the other to his ear, and discovered the acoustic properties of a tube actually amplified the internal sounds.
He could hear better through the paper tube than with his bare ear.
Way better. So Laennec spent the next few years meticulously mapping the sounds of the human chest, the crackles, the wheezes, the dead silence, and correlating them with autopsies. When he published his landmark text in 1819, he introduced the word atelectasis specifically to describe the lungs of stillborn infants that had never taken a first breath.
Oh, that makes sense. He needed a word for lung tissue that had simply failed to inflate, distinguishing it from lung tissue destroyed by disease.
Exactly. Now, pneumonia, conversely, is a very ancient concept. Hippocrates was detailing the clinical presentation. You know, the rapid breathing, the stabbing chest pain, the high fever, all the way back in the 5th century BCE. He called it parapneumonia.
But for 2 millennia, medicine treated it as an environmental or humoral imbalance.
Yeah.
Like bad air or too much phlegm.
Right. The paradigm doesn't really shift until the 1880s, when the germ theory of disease finally allowed scientists to look for a microscopic culprit. Louis Pasteur and George Sternberg independently identified the pneumococcus bacterium around 1880.
And then shortly after, Carl Friedlander identified a completely different bacterium causing similar symptoms, known today as Klebsiella pneumonia.
Right, and the realization that multiple entirely different microscopic organisms could cause the exact same macro-level lung flood created an immediate crisis.
Because doctors needed a way to tell these invisible bugs apart to treat them.
Which led directly to the development of one of the most foundational techniques in microbiology. In 1884, Danish bacteriologist Hans Christian Gram was working in a morgue in Berlin, right? He was examining the lung tissue of patients who had died of pneumonia.
And he developed a chemical staining method using crystal violet dye and an iodine mordant. Let's look at the mechanics of why that dye works, because it's brilliant. It exploits the physical architecture of the bacteria itself.
Precisely. It's all about the cell wall. Some bacteria have a very thick outer layer made of a sugar protein mesh. We call it peptidoglycan. The crystal violet dye gets trapped in that thick mesh, turning the bacteria a deep purple under the microscope.
Which is what we now call gram-positive.
Exactly. Other bacteria, like Friedlander's Klebsiella, have a very thin peptidoglycan layer that basically can't hold the dye when it's washed with alcohol, so it takes up a pink counterstain instead.
Gram-negative. So a diagnostic test used millions of times a day in modern hospitals was basically born out of a desperate attempt to categorize the bugs causing pneumonia.
And they were desperate because the mortality rate was staggering. Sir William Osler, who is often considered the father of modern medicine, captured that terror perfectly. In his 1901 textbook, he actually described lobar pneumonia as the captain of the men of death.
Wow. The captain of the men of death. That's intense.
It was accurate, though. Before the discovery of penicillin, this infection would just sweep through populations. It was killing healthy young adults in a matter of days through overwhelming sepsis and systemic inflammatory response.
So taking that historical context into the modern ICU, the physical reality of these two conditions becomes glaringly obvious. Let's examine the actual physics of how these failures play out in real time, starting with that classic lobar pneumonia Osler was fighting.
Yeah, so the clinical presentation of classical lobar pneumonia is violent and it's abrupt. A patient experiences a sudden high fever, a singular massive shaking chill called a rigor, and severe pleuritic chest pain.
That's a stabbing sensation every time the inflamed lung rubs against the chest wall, right?
Exactly. But the absolute hallmark diagnostic sign is the production of rusty sputum.
Rusty,
Yeah.
like literal rust color,
Yeah.
which is a direct result of the inflammatory cascade we discussed earlier. The capillaries become so leaky that red blood cells spill into the alveoli right along with the neutrophils.
Yes, and as those red blood cells break down, the iron in their hemoglobin oxidizes.
Oh, wow. So the patient is literally coughing up rust-colored fluid from the degraded blood in their lungs.
It is a profound infectious assault. But returning to atelectasis for a moment, the mechanical collapse occurs through very different, completely non-infectious pathways.
Right. No bugs involved.
None. The primary mechanism is obstructive. Imagine a physical blockade in the airway, like a thick mucus plug or an inhaled peanut or even a growing tumor.
Wait, if the tube is blocked, why does the lung tissue behind it collapse instead of just staying inflated like a tied-off balloon?
That's a great question. It's because the lung is a gas exchange organ, right? Blood is constantly circulating around that trapped air, so the pulmonary capillaries continue to absorb the trapped oxygen and nitrogen.
Oh. And since the physical blockade prevents any new air from rushing in to replace it, the total volume of gas slowly drops.
Exactly, the pressure drops, and eventually the surrounding tissue just crumples inward. A fascinating historical example is right middle lobe syndrome. It was heavily documented by surgeons in the 1940s.
What makes that specific lobe so vulnerable?
It's just the anatomy. The main bronchus of the right middle lobe is particularly vulnerable to compression by nearby lymph nodes. If those nodes swell up, they pinch off the airway. And that specific lobe can remain completely collapsed for years without any underlying infection whatsoever.
That's wild. Now, beyond obstruction, you also have compressive atelectasis, right, where the pressure comes from the outside in.
Right. So if a patient has a pleural effusion, which is gallons of fluid filling the chest cavity around the lung simply has no physical room to expand, so it just gets squished flat.
But the most universal manifestation of this mechanical failure actually happens in the operating room.
Oh, absolutely. Postoperative atelectasis is perhaps the most common respiratory complication in all of modern medicine. A Swedish anesthesiologist named Göran Hedenstierna utilized CT scans to demonstrate that nearly 90% of patients placed under general anesthesia develop measurable lung collapse within mere minutes of induction.
Wait, 90%? That seems completely counterintuitive. If a patient is just getting, say, a knee replacement and their lungs are perfectly healthy, why does chemical sedation instantly cause a structural lung collapse?
It all comes down to FRC, or functional residual capacity. When you're awake, even after you exhale deeply, a certain volume of air remains in your lungs to keep the scaffolding open.
Just baseline pressure.
Right. But general anesthesia heavily relaxes the diaphragm and the chest wall muscles. This physically alters the shape of the thorax. It drastically reduces the FRC. The baseline pressure drops so low that the smaller airways simply snap shut under their own weight.
I would argue there's a significant misconception about how we treat this too. Because if almost every surgical patient experiences some degree of atelectasis, the instinct for a lot of people is often to worry about infection and just reach for antibiotics.
Which is entirely the wrong approach. Uncomplicated atelectasis is a mechanical problem. It requires a mechanical solution. Administering antibiotics for a deflated lung is literally like pouring engine oil on a flat tire.
It doesn't fix the hole.
Exactly. The intervention needs to focus on re-expanding the tissue.
Which brings us to another highly specific form of structural collapse, surfactant-related atelectasis. This one historically devastated premature infants.
It was tragic. To understand this, you have to look at the physics of surface tension, specifically Laplace's law. The inside of an alveolus is lined with a really thin layer of fluid, and water molecules highly attract each other.
Right, surface tension.
Yeah, and in a microscopic sphere like an alveolus, that surface tension creates a massive inward pulling force. It is constantly trying to collapse the sac.
So our bodies naturally synthesize a detergent to fight that.
Exactly. We produce a soapy substance called pulmonary surfactant. It coats the fluid layer, breaks up the surface tension, and allows the alveoli to remain open even at very low pressures.
But fetuses don't begin producing sufficient surfactant until very late in pregnancy.
Right. So in 1959, researchers Mary Ellen Avery and Jerry Mead proved that infants dying from neonatal respiratory distress syndrome were simply missing this chemical.
Their lungs were experiencing widespread catastrophic atelectasis because the surface tension was just too high for their tiny chest muscles to overcome.
They were essentially exhausting themselves trying to inflate wet plastic bags that kept sticking completely shut with every single exhale.
That's a harrowing image.
Yeah.
But that discovery directly paved the way for Japanese researcher Tetsuro Fujiwara to develop synthetic surfactant replacement therapy in the 1980s, right?
It did. Clinicians now can literally instill a soapy liquid down a premature infant's breathing tube, instantly altering the physics of their lungs and saving their lives. It's incredible.
It really is. Okay, so we've outlined pristine textbook mechanics here. But integrating these concepts into actual clinical practice reveals massive friction. The diagnostic reality is chaotic, and it leads to significant debate within the medical community.
Oh, massive debates.
Let's start with the visual debate on the X-ray. We established that both pneumonia and atelectasis create a white patch of consolidation. So how does a radiologist actually deduce the underlying physics from that one picture?
They look for secondary signs of mechanics. In a raging pneumonia, the alveoli are filled with fluid, but the larger airways, the bronchi leading into them, often remain open and filled with air. Okay.
Since air is dark on an X-ray and fluid is white, you get a visual phenomenon called an air bronchogram.
An air bronchogram. What does that look like?
It basically looks like a network of dark, branching tubes threading right through a solid white cloud. Seeing that highly suggests an inflammatory flood.
But with atelectasis, the clue isn't really about what's inside the patch. It's about what the patch is doing to the surrounding anatomy.
Yes. Because atelectasis is a physical deflation, the lung loses total volume. It acts kind of like a vacuum inside the rigid box of the chest. Radiologists look for volume loss, or what they call a mediastinal shift.
They check if the trachea, the heart, or the diaphragm are being physically dragged and pulled toward the white patch.
Exactly. If the anatomy is distorted and shifting toward the consolidation, it points strongly to a mechanical collapse.
Now, another area of intense frustration involves how we communicate these mechanics to the public, particularly with the term walking pneumonia. It implies this sort of casual, almost pseudo-illness. Yes. That terminology actively undermines the pathophysiology. Walking pneumonia is really just a colloquialism for an atypical pneumonia. It's frequently caused by the bacterium Mycoplasma pneumonia. And the mechanics of this specific bug are actually fascinating.
Right, because unlike classical bacteria such as pneumococcus, Mycoplasma lacks a rigid cell wall.
Which completely changes the pharmacological approach. The most famous antibiotic in history, penicillin and all other beta-lactam antibiotics, they function specifically by destroying bacterial cell walls.
Oh, wow. So you cannot use a wall-destroying drug on a pathogen that doesn't have a wall.
Precisely. It renders standard frontline antibiotics totally useless. It requires clinicians to use entirely different classes of drugs, like macrolides or tetracyclines, that target the bacteria's internal protein synthesis instead.
And there's an immune difference too, right? Because Mycoplasma lacks those highly reactive surface antigens found on cell walls, the human immune system mounts a much slower, much less violent response.
Right. You don't get the sudden liver flood or the rusty sputum. The patient has genuine infectious fluid filling their alveoli. They do have pneumonia, but the inflammatory response is muted enough that they are literally still walking around.
But calling it walking pneumonia gives patients a false sense of security. It encourages them to delay medical care or go into work while actively shedding an infectious pathogen.
Exactly. It's a perfect example of how language dictates behavior. Speaking of entrenched behaviors, though, we really need to examine the incentive spirometer.
Oh, yes. This is that ubiquitous plastic device with the little floating ball inside. It gets handed to millions of post-surgical patients globally to treat that anesthesia-induced atelectasis we discussed earlier.
Right. And the physiological goal is totally sound. Force the patient to take slow, deep, mechanical breaths to generate enough positive pressure to pop those deflated alveoli back open.
However, the evidence supporting the device itself is highly contested.
Very highly contested. Rigorous systematic reviews, including those by the Cochrane database, have repeatedly found only low-quality evidence proving the spirometer is any more effective than basic nursing care.
Which begs the question, Why is an entire industry built around distributing a plastic tube if the data doesn't strongly support it?
Honestly, institutional inertia. It provides a highly visible, tangible task for the patient to do. But biomechanically, getting out of bed, walking down the hallway, and simply taking unassisted deep sighs generates similar physiological pressures. The debate pits deeply entrenched hospital culture against the reality of clinical trial data.
Wow. And that friction over clinical definitions reaches its absolute peak with ventilator-associated pneumonia, or VAP. The ambiguity between a mechanical collapse and an infectious flood actually forced a national policy change here.
Yeah, VAP became a total diagnostic nightmare. Intensive care units are filled with patients on mechanical ventilators. If a patient developed a new white patch on their daily X-ray, clinicians had to figure out, was it infectious pneumonia requiring heavy antibiotics, or was it just dependent atelectasis from lying flat in a bed for a week?
And the stakes for getting that right were incredibly high because a hospital's financial reimbursement and public quality ratings were tied to their VAP rates.
Yep. So the system inadvertently incentivized doctors to attribute that white patch to anything other than pneumonia.
Because the subjectivity was the fatal flaw. Studies routinely demonstrated that if you showed the exact same chest X-ray to 3 different ICU physicians, they would fiercely debate the etiology and rarely agree.
The human interpretation of the shadow was simply too unreliable. The diagnostic criteria just collapsed under its own subjectivity. Yeah.
So the solution wasn't to double down on reading X-rays better. The
Oh,
CDC
good.
essentially threw their hands up. In 2013, they formally retired the term VAP for public health reporting.
They replaced it with a strictly objective framework called Ventilator-Associated Events, or VAE.
VA. How does that work?
Instead of asking a doctor to interpret a hazy shadow, the new metric looks purely at the mechanics of the machine. If a patient suddenly requires higher oxygen settings or more mechanical pressure from the ventilator for a sustained period, it triggers an event.
It completely removes human bias and X-ray interpretation from the surveillance equation.
Totally. It's a stark reminder that even foundational medical terminology can be discarded when it fails to accurately reflect the physical reality of the patient.
And understanding this distinction isn't just an academic exercise. It has massive global implications. Pneumonia consistently ranks as one of the deadliest infectious diseases on the planet, particularly for vulnerable demographics like young children and the elderly.
And look at the COVID-19 pandemic. It forced the entire world to focus on alveolar mechanics. Radiologists globally had to rapidly learn the specific visual signature of viral pneumonia.
Those bilateral, peripheral, ground glass opacities on CT scans.
Exactly, representing the severe inflammatory fluid leaking into the interstitial spaces.
But applying our understanding of these mechanics has also yielded monumental public health victories. Take the development and deployment of pneumococcal conjugate vaccines, like Prevnar. They target the specific outer capsules of the most lethal bacterial strains.
Right, they train the immune system to recognize them before the massive lobar flood can ever even begin. It has drastically reduced the incidence of invasive disease worldwide.
And on a microscopic daily level, the distinction between a flood and a collapse literally dictates clinical action. When a physician stands in an ICU at 4 a.m. looking at a new white patch on a monitor, correctly determining whether that lung tissue is suffering from an inflammatory infection or a mechanical deflation determines whether the patient receives potent intravenous antibiotics, aggressive chest physiotherapy, or alterations to their ventilator pressures.
It dictates everything.
So we want to leave you with a final thought today that builds on the underlying physics of gas exchange. We touched briefly on the concept of gas absorption when an airway is blocked. But there's a phenomenon called absorption atelectasis that occurs not from a physical blockage, but from the very medicine we use to treat respiratory distress.
This is such a fascinating paradox. We instinctively view pure oxygen as the ultimate, unquestionable therapy. If a patient is struggling, we just blast them with 100% oxygen.
But the physical air we breathe at sea level is roughly 78% nitrogen and only 21% oxygen.
And that nitrogen is crucial. It is inert. It doesn't rapidly cross the alveolar membrane into the blood. It stays behind in the tiny sacs. It acts as an invisible physical strut. It maintains the necessary pressure to keep the scaffolding open even after we exhale.
So if a clinician places a patient on 100% oxygen, they are entirely flushing that protective nitrogen out of the lungs.
Which fundamentally alters the mechanics. Oxygen crosses the alveolar membrane into the bloodstream incredibly fast. Without the inert nitrogen left behind to prop open the space, the pure oxygen is absorbed faster than new gas can enter.
The internal pressure plummets.
Yes, and the lung tissue physically deflates and collapses.
The therapy designed to save the lung can actively cause its structural failure. It really forces you to question how many other unquestionably good medical interventions harbor hidden mechanical consequences inside the human body. Because the body is not just a collection of chemical reactions. It is a remarkably delicate feat of physical engineering.
Beautifully said.
When a piece of that engineering fails and casts a shadow, you always have to look past the surface and ask the fundamental structural question. Is the room filled with the wrong material, or are the walls fundamentally coming down?